but it also just gives them a brighter side of things. And whenever you bring religion to the table, I'm more than welcome to, I'm more than happy to help a client through that, because a lot of times clients may think that they can't talk about religion in therapy. And I always welcome that. And I'm glad that I'm also a Christian and I'm a member of a church, and I'm glad that my pastor embraces it and incorporates it in church as well. Like anytime that anybody needs some kind of services in church, he encourages it. So I definitely encourage both sides to it whenever clients come to the sessions.
All right. Thank you. Appreciate that. Let's see, Brother Spence. You represent an interesting perspective in this panel because you work on the inpatient side. And I think that that is a part of mental health that many people have either not experienced or are quite frankly afraid of. And probably even try their best to avoid. And yet, I think if some of us should be transparent, we would have to admit to the fact that we have loved ones who have sometimes had to be hospitalized for psychiatric care, if not ourselves. And so I was hoping that you could speak to a specific thing that comes up sometimes, which is what is an involuntary commitment?
Yeah, sure. And thank you for the opportunity, Brother Young. I would like to, so there's two main things. There's voluntary commitments and involuntary commitments. And you got to remember, state laws vary from state to state and what the threshold is. But in general terms, a voluntary commitment is when a person decides to take themselves into a mental health hospital or seek mental health to a mental health provider and and ask for that help. When we talk about commitment, we're actually talking about being an inpatient person, being hospitalized, being having to spend a night just like you would spend a night in a medically based acute care hospital in the community. The difference is being involuntary is that now you're putting a legal what I mean legal, a non-criminal, but a legal structure within that hospitalization, meaning that the provider, i.e., the medical provider, which is the psychiatrist or most times nurse practitioners as well, they in essence commit. And or some, if I'm not mistaken, there are some licensed clinical social workers as well too. They actually sign a document, and it varies from state to state. It's called different things. In Florida, it's called the Baker Act, and in different places, it's called different things. But in essence, it's a legal document saying that this person has to stay in the hospital until a licensed person clears them or allows them to go. Now, different states, it gives a turnaround time and when that this person has to, in essence, go to the court system in order to reevaluate that order. Because if you want to think about it, nobody wants to be in a hospital, first of all. And secondly, when you're basically against your will, because you're in essence taking away some human right because the person cannot leave until the licensed provider releases them. So yes, there is a legal veil, but it's a medical, it's a commingling of medical and legal veil. And I want everybody to remember this. This doesn't have anything to do with criminal. Okay. This just purely protective of the individual, where their rights to actually leave is removed for a temporary period of time.
Great. Thank you very much for that insight. I see that we do have some questions on the Q&A, so I've made note of those. We'll definitely circle back to those. I wanted to ask Dr. Weaver a question too. Dr. Weaver, when allegations emerge against someone admired in the community, how do friends reconcile the person they thought they knew with the accusations that are being made?
So, first, thank you all for this opportunity and good evening, everyone. When community figures, our friends, our family, when they face serious allegations, what it does is it triggers a painful psychological phenomena, and that is known as cognitive dissonance, right? So there is the discomfort of holding two contradictory beliefs at once, right? The human brain is generally binary. So we like to keep things as we see them, that, oh, it is just, black, white, there is no gray, there is nothing else, right? So then we fall into the good guy or the good gal fallacy, right? So then there is that. We want villains to always look and act like villains. It is so incredibly difficult to accept that someone can be a visionary leader, a generous friend, a licensed clinical social worker, even, and the perpetrator of harm. Both of those realities can exist simultaneously. There's also the idea of that we use defensiveness sometimes with self-preservation, because it's hard to reconcile that an accusation could mean that maybe my judgment of someone's character was flawed, or that they could exist outside of what they demonstrated to me. So if I could be deceived almost as someone, by someone very close to me, well, then it shatters sometimes our safety and our trust in community and people, because when people do things outside of what we know them to who we know them to be, when they act outside that way, it takes away the security blanket that we have, right? And then there's also been the process of reconciliation, right? So true reconciliation, it requires moving beyond denial, because we can't just be in denial that, well, I can't believe they would do this, or I can't believe that this happened. What needs to happen is that we have to center it's someone who doesn't make it out. The survivor is someone who has experienced a thing and is able to work through it. So it's important to center that person rather than protect the legacy of the accused, right? It means accepting that a person's public persona and contributions, that they don't erase or excuse their ability or the act of perpetrating private harm.
Gotcha. Thank you. That is that's a very profound way of thinking about that. I appreciate that insight. I want to take this opportunity to look at some of the Q and A. So one of these kind of goes back to the religious question. So certainly, Brother Louis Dor, but whomever else, feel free to jump in. Have you found someone's religious beliefs to be a challenge in resolving mental health issues?
I've, yeah, I have, because sometimes what I would recommend to a client in therapy may sometimes not align with what's in the Bible. So I typically try to ask the client, I give the client the option. I usually tell them, hey, this is what I would recommend on a mental health side, but if you feel a conviction to follow what the Bible tells you to do in this situation, I would definitely encourage you to do what you would like to do. Because my main goal as a therapist is to help guide a client through situations that they have challenges in, and not to impose what I feel like they should be doing or how they should be reacting to different religious convictions, as it if it clashes with different mental health therapeutic things that we may do in session. So I typically allow the client to make that decision on which one they would want to pursue, and I would help guide them through it in that format.
Gotcha. Okay. Thank
I
you.
like to just feel.
Yeah, sure.
I do a little bit differently, because I have clients across all faiths and not. I have atheist clients, agnostic, and then I have some, everything is what the Lord said. And I think the Lord talked to them more than the red words in the Bible. So when I have some of those people, what I like to do is I like to kind of deconstruct some of what is the super spiritual to connect it back to um, their own decision making, their own, processes, because I love when someone comes in with the prophecy, because what the prophets keep saying is, and I get that, and I'm like, well, people, if you're a believer, then you believe that they prophesy in part. So what you don't get is what the process is. So if I have to bring out some scripture and talk through that everyone had a process to go through before they got to the promise, that even the children of Israel had to go through a long process, right? Because they didn't do what they should have done from the beginning. So we talk about all those things. And if there's someone who, if they're just all set, well, God wouldn't do this, we bring in all the things that they may believe. And sometimes we have to do a little bit, of digging to help them understand that some things aren't punishment, that, there are some things that, no, the devil wasn't busy, dear, you were available, right? So we talk through all those things to make sure that we are getting to the base of what their issue is, and that I'm not allowing any excuses. And, if there's an atheist, I have to, put down, some of what I believe. I'm a church, I'm a preacher's kid. So, I'm all things Jesus sometimes. Right? So I have to, sometimes not, I don't let that cloud how I deal with my clients, because everyone has self-determination to make their own decisions. So I believe that the pinnacle of my practice is meeting the client where they are. So wherever they are, I have to get to that space in order to help them get to where it is.
Yeah, thank you. Appreciate the perspective. Another question that came up, and this would be to anyone. How do we as Black men overcome the stigma that therapy or mental health assistance is a sign of weakness, especially for men raised to always appear strong or to push through the pain or the stress?
I'll jump out on that one. With